Well, greetings and welcome everyone. I am delighted to be here with all of you today to celebrate this historic moment for the DPC movement with the passing of H.R. 1, the Primary Care Enhancement Act. And this legislation is so important, and we're here today to talk about what it means for primary care and for millions and millions of Americans. Insurance is not health care. We say this a lot in DPC circles. Since the 1920s, Americans have paid their money to insurance companies to access their doctors. And this has grown into an industry that has learned how to weaponize financial incentives in toxic payment models for their own profit. And it's a system that has been engineered to make primary care fail on purpose. This may sound dramatic of me, but trust me, ask any primary care physician and they know what I'm talking about. My friend and colleague, Dr. John Bushman, recently wrote, "When doctors have to choose between what's right and what's reimbursed, something breaks." And he's talking about moral injury in medicine, of course. And no doctor should ever have to make that awful choice. So this is the beauty of DPC, where the financial incentives are perfectly aligned with what patients need. And together, the doctor and the patient decide what and when and where and how care will be delivered. Insurance is not health care. In direct primary care, there's no insurance middleman deciding what gets reimbursed and how much, and building a bureaucratic complexity moat around their own profit margins. The dollars are direct. And the financial incentives are beautifully aligned to ensure whole person, accessible, high quality, relationship-based primary care. And there's nothing like it anywhere else in healthcare. Several of us have just been at the DPC Summit in New Orleans, Louisiana, and I gotta tell you, I attend a lot of primary care conferences, for better or for worse. And the vibe at a DPC event is just different. Typically at primary care events, we are talking about how to fix primary care. And we're trying to come up with solutions that will help us improve the system that has devalued us for decades. And we talk about these potential solutions and we analyze them to death and we fantasize about the if-onlys. If only the insurance payers would get together and agree on a common set of metrics. If only CMS would pay us more. If only we could eliminate all that administrative burden. And meanwhile, DPC has already fixed it. We've already solved it. And that means that the vibe at these events is joyous. It tastes like freedom and optimism and professional fulfillment. And the DPC movement has built a community that is thriving, that is founded on helping each other succeed, at encouraging each other, and at building momentum. And this is not what we have been taught primary care is supposed to feel like, and it's incredible. And that's just what DPC is doing for physicians. Imagine what this kind of primary care can do for patients. I've been practicing in direct care for 9 years now, and I can personally testify that DPC unleashes a power to heal like nothing else in our healthcare system. And if I feel that way, I imagine the sentiment is even stronger for our patients. Once they get a taste of that kind of primary care, those relationships with their PCPs, they cherish it, and nothing less will do. So that's the reason we're here with you today, to talk about why DPC is so important and how we have just crossed a historic threshold, a watershed moment in the DPC movement. And we're here with some DPC champions that have been fighting relentlessly for more than a decade to pass this legislation and bring that kind of primary care to more PCPs and more Americans. And today, we're going to unpack how we got here and how H.R. 1 delivers on that promise. We have a short but powerful program for you today, and we've got 3 panels of experts that will be walking us through how we got here and what DPC, the H.R. 1 Primary Care Enhancement Act means for employers, and what it means for physicians, and what it means for patients. We're going to start with Jay Keese of the DPC Coalition, who has been working tirelessly to help get this legislation passed for many years from the very beginning. And he's going to moderate a panel for us about how that legislation came to be and all the history behind it. And then we will move on to Michelle Neblett of Boeing, who will help us unpack what this means for employers. And then I'll land the plane myself by moderating a panel with my friends, some physicians who are practicing in the DPC model and have been championing DPC, and each bring a unique perspective to this conversation. So I'm very excited for you to hear from our experts today, and I'll invite Jay up to get this party started.
Great, thank you, Sarah. And I'm going to ask James Gelfand from the ERISA Industry Committee to come up, and Kevin McKechnie from the American Bankers Association HSA Council. And these gentlemen have been great partners of mine for well over 10 years in the passage of this historic legislation. Sarah, thank you for those remarks. I think you hit the nail on the head. I mean, the difference between DPC and every other methodology in primary care is that, typically you pay for 92124s and things and widgets and services, and in a DPC model, you're really, you're engaging with a physician in the purchase of a relationship over time. That is where the magic really happens. But to get into it a little bit, I'm going to take moderator's prerogative to talk a little bit about how this all started, why we're here in the first place. And as a longtime healthcare policy wonk and DC lobbyist, I have to take some blame and some credit, because James and I, at least, and probably Kevin, we were all involved in what we thought was a great idea in 2003 in the Medicare Modernization Act, where we passed a statute that created health savings accounts. There were tax-preferred accounts before them, but they didn't have the power of the HSA, which is a wonderful thing. It's triple tax-preferred income. There's nothing else like it in the tax code. That means that the money is not taxed before it goes into the HSA account. While it's sitting in the HSA account, it is not taxed. And then if you take the money out of the HSA to use it on qualified medical expenses, it is not taxed. So it's a great opportunity for savings. There was no direct primary care in 2003. So the statute, the way it reads, is a high deductible health plan by design has to be, an HSA has to be paired with a high deductible health plan. And there can be no other plan that covers things, e.g. primary care, that are in the high deductible health plan. So if you have an agreement with a primary care doctor for an affordable monthly fee to pay for primary care, even if you're paying for it yourself or your employer is paying for it, you are ineligible to fund your HSA under current rules, because the IRS looks at the things that are done in a DPC agreement and says, oh, well, those are done in an HDHP. Well, any doctor can tell you that the primary care you get as a part of coverage in an HDHP is, and I can tell you as a DPC patient, is nothing like what we have in direct primary care. So flash forward to 2013, I walked into then Congressman Bill Cassidy's office with Dr. Garrison Bliss, who was the original DPC doctor, and we told him about this problem, and Bill said, well, that just can't be wrong. I mean, that just can't be right. Primary care services are medical services, and they're not. They should be covered under 213D of the tax code. Well, 221C of the tax code says that there's all these rules around eligibility, and we've got to change them. And so we went about doing that in 2013. The bill was introduced. Senator Bill Cassidy was the first and main author of this. He is now the chairman of the Senate Health Committee. He was a backbencher on the Energy and Commerce Committee when he started this process. And so, it took a while. There's my colleagues will go through why it's so hard to change the tax code. But let me just sort of level set what it means as of January 1 of this year. Without doing anything de novo, in other words, nobody new in the country gets a new service or a new offering, and that's what we hope really happens. But just the current 61 million Americans who have HSAs are now eligible to get a DPC agreement with the doctor of their choice. So that's a powerful injection of choice into the healthcare system today. So now, moving forward, if you are a patient, you are now allowed to take up to $150 per month or $300 for a multifamily agreement, a multiple individual agreement, and out of your HSA and spend that on the doctor of your choice. If you are an employer, you are now allowed to put together a health benefit that would include a DPC arrangement, a high deductible health plan, and an HSA. And either put money as the employer into that HSA to which the patient can pay the doctor, or pay the doctor directly to take care of the employees that are part of your health benefit plan, and knit this all together in a health benefit plan that makes sense for your employees. And this should come before the deductible. So what was a high deductible health plan is a slightly less high deductible health plan under the new rules. So there's a lot going on in this bill, and Sarah made a grave mistake in giving us only 30 minutes to talk about this panel, because we've got to compact 12, 13 years worth of legislating into 30 minutes. But I think what it means for employers is just as significant for what it means for individuals, and is certainly as significant of what it means for for the physicians who are our primary audience today, and really excited about it. So I'll introduce the panel here. I'll ask them to, as they start, introduce themselves and talk a little bit about their backgrounds, starting on what this really might mean for employers and the implementation process of what employers are looking forward to. I'll introduce James Gelfand, who runs the ERISA Industry Committee.
Thanks, Jay. The ERISA Industry Committee, or ERIC for short, is a trade association that represents about 100 of the nation's largest employers. We're not insurance companies, but we do pay for health benefits for millions and millions of people. On average, the companies that we represent pay 80 to 90% of healthcare costs on behalf of their employees' families, and oftentimes for retirees as well. I figured I should start by eating my dose of humble pie along with Jay to say that in the 90s and the early 2000s, employers, just like everybody else, thought that we understand the problem with healthcare and why it was getting so expensive and we're wasting so much money on it, because you people kept going to the doctor. And so we would implement these plans that said, you're gonna have skin in the game, which means you're gonna have an incentive not to spend your healthcare dollars unless you absolutely, truly need to. And over the course of time, what we came to realize, I think before 2013 even, was that this was a design flaw. Like, the problem was not people going to the doctor. The problem was not focusing on high value care. And when we figured out what is the high value care that we should be spending money on and encouraging people to spend money on, primary care is the very top of the list. In fact, you talk to most employers, they'll say, we would love to spend as much money on primary care as we possibly can. It's reducing hospitalizations, it's reducing unnecessary specialist visits, so therefore it's saving money, which is good for the employer and good for the patients and for the families. But unfortunately, the way that we had negotiated out the language that was in the Medicare Modernization Act, sidecar bill that created health savings accounts and high deductible health plans, it just didn't allow for that. And it was a design flaw that we identified early on. In fact, some of the first legislation to start to fix that design flaw, not for direct primary care arrangements, but for other things that we identified as high value, was actually introduced in Congress in 2006. So it only took 3 years to realize, wow, we screwed up. We need to fix this problem. Of course, it then took 20 years to actually change anything. Welcome to Washington and welcome to Congress. That being said, when I think about our advocacy on improving high deductible health plans and improving the ability for people to access health savings accounts, you see a pattern that in the beginning, you had all these one-off bills, right? The people who were focused on primary care were doing their own bill. The athletic folks who wanted to allow you to spend money in your HSA on either Nikes or Peloton or things like that, they had their own bill. The employers who wanted to allow first dollar coverage of on-site clinics, we had our own bill. And the result was a whole bunch of very small constituencies arguing for bills that did not have sufficient clout to create the kind of momentum necessary in Congress to create real change. But when you start to move forward to 2016, 2017, and 2018, when our groups and other groups all got together and said, you know what, we all need to speak with one voice and tell Congress there's 60 million people in these plans. And many of them didn't choose these plans, right? For many of the employers that I represent, you may get to choose between a PPO, an HDHP, or an HMO. But for many people, their employer will only offer one plan. And so they're going to be on a high deductible health plan whether they like it or not. And we've got to find ways to improve the plans for those individuals. And it was a message that started to resonate. And we started to see momentum. In fact, the House passed legislation in 2018. Of course, it went to the Senate to die, like the vast majority of legislation does. But it was a waypoint, and it showed that there was a way forward. So this has been a really exciting time. You look at coverage of the One Big Beautiful Bill Act on television or even in the print media, and I'm not sure that there's a single story written about it that doesn't just talk about Medicaid. It's all about Medicaid. And here we are saying, there's 60 million people who are about to get a big benefit. In fact, probably many more million people because of some of the other provisions in there that are going to make it easier to have an HSA. So those people will both get access to the bank account and then also probably to DPC, because this is going to become the national standard when people see the savings and the patient satisfaction, et cetera. So this is a big deal, and it's amazing how few people are talking about it, but it's something that Jay and others, I think you've spent a decade working it, and now you see the fruits of the labor, which is really exciting.
And I want to highlight that too, because we are here to talk about the Primary Care Enhancement Act, but there's two other provisions that impact HSAs, and one would allow for telehealth reimbursement, telehealth plans to be reimbursed by employers and also come before the deductible. But another one that's very interesting, if you think about the policy rationale behind some of these Medicaid cuts, they are essentially work requirements that have been put in place for the Medicaid expansion population, which is above 100% of the poverty level. So, the signaling from the GOP here is that people in that population should, try to find work, try to find meaningful work that has affordable health benefits that come with that work. And now there are, three things that have come around to make that more meaningful by sweetening the pot with these tax-preferred provisions. Another place where people will go to get benefits if they're not going to get covered by expansion will be the exchanges. And now a prohibition that I believe was put in place in the original ACA against having bronze and silver plans in the exchanges will also be able to operate with an HDHP HSA model, which will allow those to be bolted on with a DPC model. So now a bronze level exchange plan, a person that would get a bronze level exchange plan will be able to get a plan that is a high deductible plan, which you may or may not like, but it could be accompanied by an HSA, where you can spend money in that HSA towards your DPC doctor. And we think that this is a sticky model, if you put it together, that will reach a lot of people in that lower income bracket, And the average cost of a DPC membership today is less than the monthly charge for a cell phone bill. It's about $70 PMPM. So imagine first dollar coverage in primary care for as low as $70 a month with a health plan you get. I mean, my HDHP that is in the exchange does not offer that kind of care today. Kevin McKechnie from the HSA Council, let's hear a little bit about, I'd really like you to cover sort of two things. I know you've been tracking this very closely with the IRS over the years. We've all been together trying to work with regulatory changes to the IRS. So I'd love to hear what this means to the HSA industry writ large. And what challenges might we face in implementing this law in the very short window of time that we have between now and December when this takes effect?
Well, thank you. It's nice of you to have me, first of all. Appreciate the opportunity to visit with you. And I appreciated the introductory comments, which is, I'm not in healthcare. They call those people doctors. I'm a financier type, and we work on financial policy. And the collision of medicine and banking, or medical banking, is where HSAs live. And if we had to do it all over again, I did enjoy that conversation, because high deductible health plan is nobody's idea of a marketing triumph. It's HSA qualified insurance. And at this point, everyone in the room probably has a high deductible health plan. Most of those average deductibles are at least as high as the minimum deductible for HSA qualified insurance. The IRS is a very mature regulator, and they're very thoughtful people. That's why it takes so long to get anything out of that organization. But try to remember, in 2003, the Medicare Modernization Act was passed in November, and they had just 45 days to stand up all the regulations around HSAs. So when they need to move, they can move with alacrity. And we hope they do that this time. And as we talked earlier, the joke here in Washington is never to use the word manana, because of the sense of urgency inherent in that word. And so we don't. Everything usually takes forever to get done. I don't think that'll be the case here. And it's because where we are in the cycle of insured benefits, it's August. Most of the state insurance departments are already evaluating bronze and catastrophic plans for sale in the states. And so now that there's been a change, the IRS has to move quickly so there can be amendments filed in those state insurance departments. And you're right about the kind of people we're reaching for. Our annual study with a partner company called Devenir Research out of Minnesota just came out. 64% of all those 60 million people with HSAs come from zip codes where the household income is less than $100,000. And so this is really a product that is reaching people at the entry end, at the modest end, at the working end of our society. And that's the people that need the help to spend money where it's required. All of this out-of-pocket responsibility is growing. And so the best way to address it quickly is to make sure you get a chance to pay for it with tax-advantaged dollars. To your point, Jay, there is no other account that has these tax advantages. And so it's exactly the right policy for exactly the right group of people at exactly the right moment in time, because there isn't any other way to make it cheaper. Medical inflation is higher than real inflation. I'm not exactly sure what those numbers are, but we know that dynamic exists, which is why it keeps getting more expensive. What we want from the IRS is, and for those of you who don't know how they tend to regulate, it's not usually a great big long form. The HSA rules are in Q&A form for the most part. And so we've taken the liberty of trying to determine what cues they should ask and what answers we should provide. And we hope there's a harmonization moment out there where essentially the government agrees with our interpretation of the law. And one of those places that I know there's going to be some friction is it's very good. The average DPC cost per month is much less than the cap, because if you have a individual DPC arrangement that's $1 more than the cap, then you're no longer HSA contribution qualified. And that's a problem, and people need to understand that. And just like that, we're all the way back to our 20-year effort at educating the American population on how all of these things actually work. And most people are too busy doing their jobs, working on their families, to pay attention to the kind of product that you can be forgiven needs a lawyer and an accountant to figure it out. Sometimes you do. And so we're looking for clear questions, clear answers to give Americans the kind of guidance they need. And that number, 60 million people, it's an old number. That number is from December 31st of last year. And so we know there's many more people, millions more Americans this year enrolled in HSAs. There's about 41 million accounts. And so you apply a standard coefficient to get an idea of exactly how many Americans are in it, because we be expressly clear, we don't exactly know, right? We don't know what the actual number is. We just extrapolate from the number of accounts there are. And that's what our study shows everyone, and it gives you the demographics. And I encourage you to go and read it, and if you have questions, give us a call. But will the IRS do this quickly? We hope so. We're going to encourage them to do that. Will they do it accurately? That is their hallmark, is it not? They do it accurately, and there's a thoughtful group there that's working on it. We all know them. And I would expect we'll collaborate as best we can to get them that kind of information, and then collaborate with all of you to get that information out to Americans so they know what we're talking about.
I'm glad you brought up the $150 a month limitation on this exception to the rules. I think that's right. At $151, essentially you have current law.
Yes, that's right.
So there's really no change. So this applies to affordable direct primary care agreements. And understand, again, we did a study with Milliman in 2020 and found that the average DPC benefit was about, I believe it was $71 PMPM. So that's double the national average for the cost of one of these, indexed for inflation. So it is intended to make this rule applicable to affordable DPC agreements, not concierge plans, which have a different methodology. And so, again, another thing that was interesting in the battle that we had over H.R. 1, this provision was put in, along with the others, many others, by the House of Representatives. And then it was stripped when it came into the Senate, because the Senate wanted to focus on, the Senate did not want to have any additional spending in the bill. Well, this afforded us the opportunity to send a very strong note into Senator Crapo, the chairman of the Senate Finance Committee, and Senator Cassidy was at the helm, signaling this message that this isn't spending. This is a $2.81 billion tax cut that allows Americans to put their hard-earned dollars into a tax-preferred account to spend it on primary care, which will then reduce downstream expenses in the Medicare and the Medicaid program, and cause people to have fewer days of missed work, increase their incomes, and get more promotions, and put more money back into the tax coffers. So, did we get any credit for that, James?
Well, I think there were many provisions that were stripped out in the House, right? They made it through the House and they were stripped out by the Senate, and there were very few that came back and were in the final bill. And so this is a classic advocacy exercise. You make it through the House, you're gone in the Senate, and now you've got this one chance, and you've got to prove how good are your arguments, how strong is your constituency, how much attention can you bring to this, can you get media, can you get constituents' boots on the ground, can you get a strong showing of support. I think it goes to show.
72 hours.
Right, very quickly, very tight turnaround, right? But I think it goes to show the strength of this provision and just a couple others, and the constituencies and the experts and the leaders who are backing it, because there's plenty that didn't make it over the finish line. And I've been telling people there's a reason why they called it the one big beautiful bill, and that's because it may be the only bill, at least the only major bill that makes it across over the next 2 or even the next 4 years. So if you didn't make it on this bus, there's going to be fewer and fewer chances to find another bus to get to the station. So I think for those who didn't make it, they're looking, they say, wow, those DPC guys had it going on. They did something right. And I think that's
it only took a decade.
I think it's also interesting, one of the things that you mentioned, Jay, about how almost every plan now has a high deductible, but it doesn't meet the definition of a high deductible health plan. And one of the reasons for this, if you go and you ask employers or patients, why are you choosing this plan? It still has a high deductible, but you don't get this wonderful tax benefit, which, by the way, is so good that you should do the HSA before your 401k unless you've got a match. Do up to the match, then do the HSA, then max out the 401k. Anyways, The reason why they'll give you is because they want first dollar coverage for primary care and in some cases for other physician office visits. They'd rather have $20 copay is so important, or no copay at all is so important. Why is this relevant? Because now that DPC can be integrated with a high deductible health plan, there's going to be millions of people who that calculus is going to change. And they're going to say, well, wait a minute, I actually should enroll in the plan that I can get this wonderful tax benefit, because as long as it's paired with DPC, I still get that benefit that I otherwise was staying in this very high deductible PPO for. So I wouldn't be surprised if that 60 million number jumps significantly.
Absolutely.
As the market matures and these things get more paired together. There's going to be people who are enterprising and thoughtful about shopping, right? And they're going to go out and they're going to find their own DPC. But I think especially as employers start to get on board and pairing these things together, you're going to see a major shift. And so this bill is going to be far more impactful, perhaps, than our good friends at the Congressional Budget Office and Joint Committee on Taxation actually knew. But be thankful for that, because if they knew that, they might have upped the score and said we were going to increase the deficit even more.
I agree with you.
Well, that's great. So the table's been set. Now it's time to execute. America's physicians, employers, and frankly, patients need to step up and make the choice. You can choose between insurance-driven care, or you can choose a plan that is front-loaded by a doctor of your choice who knows your name, that doesn't have to put an EHR cart in front of them to figure out what's wrong with you when you walk in for an appointment. And we're going to be hearing a lot today from the employers who plan to do some of that execution, and from some of our best DPC docs from around the country, big practices, small practices, and everything in between. So I think we're at time. With that, I'll hand the mic back to Sarah, and we'll move on with the rest of our program. Thank you so much. We really
Thanks for
appreciate
having
you
me.
guys being here today.
Good to see you.
Wonderful job. Thank you so much, all of you.